My name is Angelique Falcon, and today I'm going to discuss lack of physical activity in middle-aged African American women in low-income communities. We'll be discussing constructs and how they aid in identifying barriers and bring an understanding to the underlying behavior of why African American women lead sedentary lifestyles and how interventions are applied to improve their health and health equity in increasing physical activity. Research shows that with the positive benefits of daily physical activity, half, or more like 49%, of African Americans live in sedentary lifestyles compared to 39% of white Americans. This gap is an example that the lack of physical activity leads to an increased risk of death and comorbidities in the African American community. African American focus groups reported barriers of unsafe walking areas, cost of exercise facilities, lack of child care, transportation issues, and physical health challenges as detriments to lack of physical activity. Physical activity is a challenge for many African American women. Only 36% meet the national recommendation of 150 minutes per week of moderate to vigorous physical activity. Adults need to move approximately 150 minutes with a moderate intense physical activity a week and 2 days dedicated to muscle strengthening activities. Some examples of moderate intensity physical activity include dancing, water aerobics, riding a bike, gardening or lawn work, and brisk walking. Examples of muscle strengthening activities include yoga, handheld weights, and exercise bands. The social determinants of health significantly impinge African American women and how they can care for their families and themselves. Here we have a map from the CDC that shows the differences in the prevalence of physical inactivity in the United States. This map exists by race, ethnicity, and location. If you look close, you can see that the southern states have a greater than 30% prevalence of physical inactivity, including Puerto Rico. When looking at the social determinants of health, you can see that African American women face a myriad of barriers compared to other cultures. The Healthy People website lists the same social determinants and health issues that African American women reported in the multiple studies that we'll review today. They have voiced the same for fear or for challenges. The risks associated also reflect the same concerns that deter them from participating in physical activity. Socio-economical model to physical activity in African American women. We know that the outer level influences the inner levels, all the way to the individual. The individual or interpersonal level is where researchers found that African American women need a purpose for physical activity. They voiced that the women felt that finding time to exercise was a challenge, and chores such as housework are not physical exercises to them. On the interpersonal level, when dealing with families and friends, these relationships help them form the actions and views of how they look at exercise. The organizational level focuses on institutions that have accessibility or the lack of availability, such as health clinics, schools, and exercise facilities, parks, and walkways. Environmental impacts or one's ability to adapt to a physical activity in their own home surroundings. The community level is where the cultural values and norms present themselves. Here is where African American communities look to faith and community leaders to give guidance. According to Parker et al., African American women lead the nation in lack of regular physical activity. They are the most significant risk for diabetes, heart disease, and related depression due to obesity. Here at the community level is where change has its most significant impact. Public policy rounds out the ecological model with local, state, and federal laws and policies. When trying to understand the underlying behavior of why African American women lead sedentary lifestyles, we need to identify the barriers that they face. The following behavior theories, along with their constructs, will aid in helping develop an intervention that, when applied to this demographic, should assist in more significant health equity and increase movement from the whole family. The behavioral theories are the precautionary adoption process model, the health belief model, the trans-theoretical model of change, and the social cognitive theory. The precaution adoption process model is a stage model where people pass through a stage progression. The theory helps us understand that African American women may be unaware of a particular health risk or just unengaged from the risk based on lack of knowledge. This stage is where optimism bias is reflected, as they have intent on starting to change but do not follow through as they see the health risk will affect others but not themselves. This thought process reflects its stage 3 and 4, respectively, on deciding not to act or deciding to change. Stage 5 is also included in here. Intention is a necessary construct for behavioral enactment. No one reports performing a physical activity with not low intention, per Rhodes and Yao. The precaution adoption process model study suggests high efficacy is needed for more excellent intentions, as in stage 6 and 7, acting on change behavior and maintenance of behavior. This study shows that attention-grabbing reminders of the behavior change's expected outcomes should increase motivation. When looking at trans-theoretical model of change, the trans-theoretical model of change considers past behavior conduct with the prediction of future movements in physical activity. There was a study by Paschal et al. That focused on the relationship between low-income and medically underdeserved African Americans in Kansas. The households were earning less than $20,000 a year from ages 18 to 30 years old, mostly female with a high school diploma. This model indicated that the group needed better health and increased physical activities, as most were very inactive with other negative health habits and issues. The concerns were, again, cost of fitness centers and classes, cost of daycare during lessons, and the locations of the courses offered. The lack of commitment is a bit concerning, as it allows a person to revert back to the pre-contemplation stage, where some early behavioral steps to change have been started. This study showed that in order to close the health disparity gap and move them into the study for the preparation stage and beyond, education should be geared towards them culturally and create an environment of resources that promote upward movement to support changes. The health belief model is a value expectancy model. Here, behavior changes weigh the benefits against the cost of perceived gains. The University of Oklahoma interviewed African American women on campus based on their opinions of perceived barriers. Some of the barriers were not being active because they did not feel safe on campus, susceptibility for not being active for fear of injury, severity, not being active because it will cause illnesses, cause to action by waiting on a doctor to give recommendations if physical activity was needed, and self-efficacy was measured for each woman's confidence in physical activity. What they found was those perceived behaviors were higher for those who were in the inactive stages. And once they were inactive, they did not really pick up and embrace physical activity. They continued to report lower feelings of perceived severity, which also continues on into the middle age for African American women if they don't turn that behavior around. For social cognitive theory, we saw the immediate environment observing others and modeling these behaviors. So here we have African American women who were more significant personal barriers to physical activity due to their low economic status again. So this theme continues out through all of our studies. We saw that barriers reported were negative self-efficacy, or lack of social support, decreased outcome expectations, and decisions about increasing activity. The social cognitive theory begins first by addressing them with the knowledge and lack thereof that African American women understand how much physical activity is needed for improved health. Education incorporates 150 minutes of physical activity weekly along with strength training. The negative outcomes to physical activity stem from social structural factors that they live in. Again, lack of sidewalks and safe locations, or not having to start an exercise program, or finding workouts unenjoyable. We know that at social cognitive theory that we also have modeling. So parents are role models for children. It is no less evident when it comes to how children mimic them in their thoughts and actions. According to Wetcher-Ritchie et al., knowledge is a precondition for behavioral change. Parents receive education on the benefits of physical activity to begin 3 times a week that will also include their children with them. Incorporating these changes result in positive outcomes such as weight loss, improved relationships between parent and child, disease prevention, and improved diets. With social cognitive theory, it allows identification to meet the women at a level they can relate to. When we look at these applied interventions and start to rank them, we notice that the precautionary adoption process model may not be the best way to reach African American women because it is requiring that it needs constant reminders to be the best for motivation. If this is the case, then physically active barriers, it will rely heavily on volunteering strategies, and we see that people will not continue on with their program. When trans-theoretical model of change, we notice that in those studies, researchers suggest developing interventions that begin with a focus on incorporating healthy foods first, then implementing physical activity. But if you live in a place that has a food desert, it could be a challenge to get those healthy foods. Pascal et al. Also noted that they focused on predictability of the African American adolescent child. And in comparison, that we found that the girls lacked physical activity from childhood that then continued on as they went into adulthood and middle age. The conclusion was that additional studies are needed to address youth readiness to change behavior and social barriers. The health belief model was not enough to motivate women to keep up with the lifestyle changes. So it was not one of the best to fit to help with African American women in their movement. On the study of social cognitive theory, African American women did not realize that the type of physical activity and the intensity at which it is performed directly affects their health benefits. So participants' families provide a variety of affordable activities and help the women set short-term achievable goals. Social cognitive theory fit better because we found that age was a direct predictor of modifiable behavior changes. When it comes to my interventions, we also look at social cognitive theory because it has appropriate constructs needed to meet African American women at the level that they're at. The women affect their cultural position in the family dynamics, so older women want to hold on to that. African American women use their phones for social media more than any other race. So developing a study where they were using cultural relevant Facebook posts and text messages to send motivating messages and to contact them on Facebook in groups was quite successful. The women followed through and showed improvement and increased self-efficacy. Using vicarious experience and an active attainment would best serve the population by introducing the benefits of physical activity in their youth and creating a modeling behavior by their parents. So starting off in the youth will also be quite helpful to get these kids to move with their families. My plan would be to start with a group of 10 women, providing low-cost accelerometers or pedometers to gauge movement as a baseline, and then create weekly goals by either steps or physical intensity that they can reach using the social cognitive theory. The task-specific goal will increase self-efficacy, and the participants will be able to see positive outcomes of increased movement. The group can create weekly challenges to motivate each other along with a reward system for achieving goals. The group would then instruct to begin with brisk walking for the first week. Some days will feature healthy foods in a calendar that will be incorporated into meals and reminders to keep doctor's appointments. Children and extended family can participate in the daily changes through vicarious learning, along with community outreach that should begin at the local churches or community centers with health fairs or just local events on the weekend. Organizing in school outreach begin with kids that may attend after-school care programs with teaching them healthy foods to change out or just packing and choosing good lunches. Introducing physical activity and healthy eating habits during their youth may introduce motivation to continue as an adult. Also, sending them over to the nationaltoday.com. The African American Women Fitness Month is April 1st. The main ethical concerns are liability of starting a physical activity program, lack of trust in someone new, and finding a certified health specialist. Thank you for your time.